The etiology of bone defects includes mainly musculoskeletal tumors, bone sarcomas, and metastatic bone disease, and rarely revision arthroplasty procedures. The management of bone defects requires a multidisciplinary approach, and the successful surgical treatment includes appropriate eradication of pathological tissue and reconstruction of bone and soft tissues, including vital structures. And to save patients' extremity, all these steps should be appropriate and coordinated. Eradication of pathological tissue and reconstruction can be done at the same time or can be done by stage surgery. Bone reconstruction can be in the form of endoprosthetic or biological reconstruction, and soft tissue reconstruction is associated with all when required. Soft tissue reconstruction provides coverage for bony reconstruction, decreases dead space, and prevents seroma, hematoma, or infection, and contributes to function in certain circumstances. The main indication for endoprosthetic reconstruction is periarticular metaepiphyseal malignant bone tumors, and rarely revision arthroplasty. This is a proximal femoral Ewing sarcoma managed by endoprosthetic reconstruction following white resection. Abductor mechanism restoration is crucial in this location. And this is the 5-year follow-up of the patient. A distal femoral parosteal osteosarcoma managed by resection and reconstruction with a modular prosthesis. And this is the 5-year clinical and radiological follow-up of the patient. Another distal femoral osteosarcoma, a commonplace for bone sarcomas, again reconstructed by a growing prosthesis and local muscle flaps. And this is the 8-year follow-up of the patient. Under certain conditions such as skip metastasis or extensive tumor involvement, a total femoral resection is required and managed by a total femoral prosthesis. Endoprosthetic reconstruction is frequently required after resection of metastatic bone disease, particularly in the proximal femur, followed by distal femur. And occasionally, diaphyseal metastases are resected segmentally, and intercalary prosthesis can be used. Again, occasionally, local aggressive bone tumors, such as a giant cell tumor of bone, in this case, or soft tissue sarcoma surrounding the femur, in this case, are candidates for resection and endoprosthetic reconstruction. Following primary or revision total hip or total knee replacement, a large bone defect can be the final result, and a reconstruction by a modular tumor prosthesis is required. This is a primary total hip arthroplasty patient, and the patient had a periprosthetic infection, and following serial debridements, a bone loss was created, and you see the final result. The whole femoral segment was reconstructed by a nail and surrounded by a polymetal methacrylate. And then after the infection was overcome, in the second stage, a total femoral endoprosthesis was applied to manage this total femoral bone defect. Another example, again, it's an osteosarcoma patient which was managed by resection and an endoprosthetic reconstruction by a growing prosthesis and a megaprosthesis infection in midterm. Again, a two-stage revision was performed in this patient. And as you see here, free flap was required. Free flaps of local muscle flaps are frequently required in revision procedures. A patient with a primary knee prosthesis had distal femoral fracture, but internal fixation did not provide bony healing, and an infection was developed. This patient underwent a two-stage revision with a modular prosthesis. When we come to biological reconstruction of bone defects, we frequently use vascularized bone transfer and combination of vascularized bone transfer and allograft or recycling autograft. This is a proximal femoral osteosarcoma in a 6-year-old boy, and which was managed by white resection and then a combination of recycling bone and an osteoarticular vascularized fibular graft. And you see the 2.5-year follow-up of the patient. And partially remodeled femoral head provides good motion, even though a mild limping persists in this location. Another patient, again in the proximal femur, a Ewing sarcoma in a 9-year-old boy, and again, following white resection, the bony defect was reconstructed by recycling bone and vascularized fibular graft. And you see the early postoperative and 2-year follow-up radiographs, which shows complete healing of the fibular graft and a good incorporation of the fibular graft and the surrounding recycling bone. Another patient, a 15-year-old girl with Ewing sarcoma of the femoral diaphysis, again following resection, a combination of a fresh frozen allograft and vascularized fibular graft was performed. You see the 1-year follow-up, 2-year and 3-year follow-up radiographs of the patients, again showing complete healing of the fibular graft in both ends, hypertrophy, and incorporation with the surrounding allograft. Another osteosarcoma patient in the distal femoral diaphysis, and again a combined technique, a combination of recycling bone with vascularized fibular graft, which was fixed with a plate, and at 2-year follow-up, again we see the complete healing of the fibular graft and the recycled bone, and good restoration of the bony defect. And another example, again, a 6-year-old child with an osteosarcoma of the distal femoral metaphysis, and again, following white resection, the bony defect was reconstructed by recycling bone and the vascularized fibular graft in this patient. And following lots of tumor cases, a trauma case in a pediatric patient, a 7-year-old child who had a train accident in a play field, and you see the initial clinical photo. The whole femur, almost the whole femur, is exposed. Severe soft tissue damage. First, a serious debridement and an external fixation was applied. Then the patient underwent serial debridements, and As a result, a large bony defect in the femur was formed, and then we performed an arthrodesis by a fibular graft, vascularized fibular graft between the remaining femur and the tibia. And you see the healing in the femoral side and also in the proximal tibial side here. And of course, the patient had a shortness of this extremity, and then we just started to lengthen the bone from the tibial side. So in summary, the type of reconstruction should be individualized for each type of bony defect in the femur. Endoprosthetic reconstruction provides immediate motion with higher complication rate, especially in mid and long-term follow-up. Biological reconstruction requires a longer time for independent motion, but when the graft unites and hypertrophies, it prevents a more durable solution. Soft tissue reconstruction should be considered after any type of bony reconstruction to achieve good results with low complication rates. Thank you.